Today's presentation is entitled Get Paid for the New Chronic Care Management Code. Our panelists include Dr. Richard Hodak, Chief Medical Officer, and Marina Pascali, Director of Clinical Products at Vital. Marlene McIntyre, Quality and Risk Management Director at Northeast Georgia Diagnostic Clinic, is also on. Today's session is moderated by Sharon Panbanker, Vice President of Population Health Strategies at Vital. Before we begin, I'd like to review a few housekeeping items. One, if you are on the call, please mute your phone so we can eliminate any background noise. Secondly, you can use the control panel on the right side of your screen to minimize or expand the panel just by clicking on the arrow in the upper right-hand corner. You can submit questions using the question panel located near the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation. We have quite a few attendees today, so if we do not answer your questions, we will do our best after the webinar to follow up with you. Finally, all registrants will receive a copy of today's presentation, a link to the recording, and a copy of a new white paper on chronic care management within 24 hours after the webinar. The information will be sent to you via email in which you registered for this webinar. The email will also include a brief survey that we'd like for you to complete about your plans on the new chronic care management code. In return for completing the survey, we will share the results with you. At this time, I will turn it over to Karen to begin the webinar. Karen, take it away.
Thank you, Renee. We are very excited to have so many people on our webinar today. The chronic care management fee is, very understandably, garnering lots of attention because it allows practices to get paid for what they are likely already doing for many chronically ill patients, but also to begin doing this for those who they may not have the resources to reach without the additional revenue support. The CCM fee is a very valuable population health management tool that clearly aligns with value-based care, the triple aim, patient-centered medical home, and meaningful use initiatives. As Renee said, and as you can see on this slide, our panel today includes Dr. Richard Hodak, Vital's Chief Medical Officer and Senior Vice President of Product Strategy, Marina Pascali, PhD, Vital's Director of Clinical Products, and our special guest, Marlene McIntyre, who is a longtime Vital client. She currently serves as the Director of Quality and Risk Management at Northeast Georgia Diagnostic Clinic, a large multi-specialty practice in Gainesville, Georgia. Marlene holds primary responsibility for several key areas for the clinic, including quality, risk management, compliance, patient access, and PCMH, and now the CCM program as well. During this presentation, we will ask the audience several real-time polling questions to learn where your organizations are heading with regard to the new chronic care management fee. Now I'd like to turn it over to Marina and Dr. Hodak. Next slide, Renee.
Welcome and thank you. I know we have almost 800 people on our call today. There's been a lot of buzz about CCM. Assuming our audience wants to know more about how to get paid for providing the chronic care management services. CMS has created, as you all know, a new service code that can be used to bill for time spent providing non-face-to-face care coordination services. And the headlines reflect some of the enthusiastic reception this has had, citing this in some cases as an important step in primary care payment reform, as well as another building block really in population health infrastructure, where we're moving towards a greater emphasis on ongoing care management that hasn't had the attention in our system before, really. However, there's also some skepticism. The requirements that must be met in order to bill for this new code pose a challenge for some practices. There may be additional technology that's required or additional staffing. Some of our clients are asking, is the ROI there to invest in this? And some are wondering whether the patients will agree to a monthly copay. So in today's webinar, we're going to begin with a brief overview of some of the key requirements that must be met to utilize the new service code. Can you go to the next slide, please? We will then discuss why CCM is important for population health, and share with you some insights on how practices can evaluate this opportunity. We will then ask you, our audience, some real questions, as Karen stated. We'll do some real-time polling so you can also see what your colleagues are thinking. And then we'll hear from Marlene McIntyre about how Northeast Georgia Diagnostic Clinic is getting paid for chronic care management. And although I know Marlene will touch on the different tools they are using, just wanted to let the audience know that we will be holding a future webinar specifically on FITEL's products and how they can assist you with standardized care management, time capture, and reporting. I think we can go to the next slide now and talk a little bit about, at a high level, what the new service code is. This is a new CPT code.
Marina, can you please pick up the headset? We're getting a little bit feedback on the line.
Is that better?
Go ahead and proceed.
Is it okay? Thank you. Apologize for that. The new CPT code is code 99490, and at a high level, this code is for the delivery of about 20 minutes of non-face-to-face care coordination services. These services are for Medicare fee-for-service beneficiaries with multiple chronic conditions, and they can be delivered by a variety or large range of certified clinical staff, which we'll talk a little bit about later. The service can be billed every calendar month, and it is paid at approximately $42 per month, although that does vary by region. Let's take a look at some of these components. On the next slide, just to focus on and make sure everyone's aware, this is only for the Medicare fee-for-service beneficiaries, and there's been a lot of questions about which conditions, how many conditions does that beneficiary need to have in order to be eligible. The guidance here is that the patient must have at least 2 or more chronic conditions that are expected to last at least 12 months or until the death of the patient. Furthermore, the chronic conditions place the patient at a significant risk of death, acute exacerbation, decompensation, or functional decline. So the focus here really is not on a chronic condition that the patient may not affect the patient's future health, but really one that the services that are paid for, including the care plans and all of the non-face-to-face care coordination, really apply. Now, there's no list of chronic conditions, so this is something that each organization will have to identify and decide which of those Medicare fee-for-service beneficiaries and with which conditions do they want to focus on and target. We'll be speaking a little bit more about that. Dr. Hodak will help us with that a little bit. Just a note here also is that the certain patients are excluded that are not eligible for this program. Patients who are in other grants or other programs like CPCI where these types of services are already covered, you may not bill for this new code for those patients. So remember, those need to be taken into account. On the next slide, the patients, how do you enroll? An important point here is that to initiate the service for the CCM, you really need to have a face-to-face first with the patient. That can either be in an annual wellness visit or an IPPE or some other comprehensive evaluation and management visit. The objective here is that there must be that face-to-face discussion with the patient because in order to enroll the patient, there needs to be written consent. And during this face-to-face, it's expected that the providers will discuss with the patients the services that will be offered, the types of access, rules and regulations around data sharing, the cost-sharing aspect of the service, as well as how the patient may remove themselves from the service in the future. Now, the patient can only, or the beneficiary can only select a single physician who's going to be able to bill for these services. Furthermore, this decision to either accept or decline must be recorded in the patient's medical record. And for this has to be one of those technologies that are certified, in order to comply with the requirements. The scope of services on our next slide are really vast. There's a lot of documentation available. We won't really have the time to go through everything that is covered in terms of the services that can be provided. But certainly keep in mind that although there are certain physicians who can bill, there's a broader array of personnel who can actually provide the service. Part of the service is to create a care plan, a comprehensive individual care plan, to have that documented and managed. There are various access requirements, including providing patients access, 24/7 access to their care team. The certified technology component that is also required in these services is not required for all of the services that are provided, but we listed out here some of the items for which you will need to use a certified technology, including recording structured data, the fact that you've documented the provision of a care plan to a beneficiary. The care plan itself does not need to be in the certified technology, but the delivery of that care plan to the beneficiary must be documented. There are various formatting requirements for clinical summaries, as well as documenting the communications that you have with either home or community-based providers in the coordination of the care with that patient. With regard to the billing, which is the last high-level review that we're going to do on the CCM coding itself, this is on our next slide. There we go. We've already mentioned that you need to provide that annual wellness visit or the IPPE or comprehensive evaluation before billing for any 99490 codes for the patient. The code can be billed once per calendar month, and only one practitioner is paid per month. So there are a number of practitioners who can bill for this. It could be a physician, a certified nurse midwife, clinical nurse specialist, nurse practitioners, physician assistants. Although, as I said before, there are other physicians or other types of providers who can actually provide the service. These are the ones that can bill for it. And you must have at least 20 minutes of services that are provided and documented. So documenting not only what service was provided, but the amount of time needs to be documented to ensure that at least 20 minutes of care coordination were provided during the month. Just another note to be aware of is the 99490 code cannot be billed during the same month as certain other codes. And these are TCM, home health, certain ESRD services. The idea there is that the patient will already be receiving the types of service that are covered under 99490 and the other codes, so it's perceived as a double billing situation. There's a lot of information. We are going to provide you with some resources at the end of the webinar so that you can go and dig into some of the regulations and some of the information that has been published regarding the CCM code, but wanted to give a brief overview, and now I'm going to hand it over to Dr. Hodak to tell us a little bit about the CCM and how that fits in with population health management. Dr. Hodak?
Yes, thank you, Marina. Go to the next slide, please. I'm going to take a few minutes and show a couple of slides that will really show you the importance of these common chronic conditions to Medicare. This is a hypothetical population that I'm showing you here, but where 20% of the population are Medicare, and that number can vary by different organizations. In fact, Marlene is going to be able to show us later that that number is 60% at her organization. So whatever that number is, the most important point that I pulled out of this chart book review is that 14% of the Medicare population has 6 or more conditions. I mean, that's a phenomenally large number of conditions, you know, in the Medicare population. And if you would just focus on those 14%, that would be 70% of the cost. Go to the next slide. So the average cost for 6 or more conditions is $31,000 per year. If you go ahead and do that calculation, 31,000 times 14% of your Medicare population, you will see that this is a very, very large number. And not only is it high cost, I need to be able to have the multiple chronic conditions, but it's also the greatest opportunity and need for care coordination, because they have the multiple conditions and everything that goes along with that. They're seeing multiple physicians, many of them seeing several specialists. They're on 14 or more medications, which is not unusual. In fact, as I'm looking at some of these patients and the data that I have, 14 is a very low number. They're on many, many more than that. They all have care opportunities and lifestyle risks for each of those conditions, and they account for the most admissions and readmissions in the Medicare space. It's also a likely duplication of lab and radiology tests because the care is not being coordinated. So the rationale to do something for these multiple chronic conditions is quite clear. Next one. In this last slide I'm showing you the prevalence of the common conditions, the common chronic conditions that Medicare evaluated. I think there's 15 or 16 on this slide, and these are the ones that they analyzed and developed all of the data that's in that chart book. You'll see the prevalences are quite high. Everything is about double what it might be in a non-Medicare population. For instance, if you focus in on diabetes, we're talking about a 28% prevalence of diabetes in these Medicare patients. So one way you could approach this is to go ahead and take conditions that are in this list. These are obviously the ones that they found the most useful. They did not, however, publish this as being the conditions that you would go ahead. That's right now, as Maria said, it is you pick the conditions at your organization. But these would be good ones to start on, and these would also be conditions most likely to last for more than a year. Most likely would be the people who would become acute within a short period of time and either lead to complications or to go into the hospital. So concentrating on these are the ones that are probably going to be the most useful. And again, you can review the chart book, and you can see dyads and triads, 2 conditions or 3 conditions that are the most prevalent and the most costly, and you can make your final decision, after doing that. All right, back to you, Marina.
Thank you, Dr. Hodak. So obviously there's a good reasoning and clinical reasoning for creating this code and providing physicians with the incentive to deliver these kinds of non-face-to-face services for patients who have multiple conditions and who would benefit from the care coordination that this new service aims to support. As we discussed with a number of organizations across our client base, we realized that the decision, though, is not as simple as doing the right thing. There is a financial decision that is also being made by many organizations. And I think I can hear feedback again. I just want to request that everybody put their phones on mute. Thank you. So on the next slide, we've kind of laid out a model. We're not going to deal with all the details of the model, but thought we would highlight for you some of the key drivers that we are seeing being used and that are critical in determining how to support and how to pay for this kind of service. So on the left-hand side here, we've identified key revenue drivers. So as you're looking at your organization and trying to figure out how much revenue does this really mean for you, obviously the first part to start with is the percent of your patients who are eligible for the service. So those who are fee-for-service Medicare, who aren't involved in other programs. For some of you, that might be a fair number of patients that are going to come out of that eligibility group. For others, it may not be much at all. And, of course, those who have 2 or more conditions. And if your organization is going to focus on 4 or more conditions first or 6 or more conditions, you need to factor that in there as well. And the second piece is that related to what percentage of the patients are actually going to consent and enroll in the program. I know I've heard a number of questions about, wondering, will patients really pay for the copay and will they agree? We're going to hear a little bit more from Marlene on her experiences at Northeast Georgia Diagnostic Clinic. But again, this is an important number to estimate. The last part is thinking again about the group of patients that you expect to enroll. Out of 12 months, how many months do you think you'll be able to deliver 20 minutes of service for your patients? It may very well be that you're already delivering this service to your sickest patients, and that's an easy number to reach, and you'll probably go over 20 minutes. For other patients, if you're looking at patients who have 2 conditions, the conditions, are hypertension and, I don't know, CAD, whatever that might be, it may be that a patient who is well controlled will not really need 20 minutes of non-face-to-face care coordination every month. So be aware of that, the population that you're enrolling, and how many months of service do you really think you'll be able to bill for. And at a high level, those are key drivers on the revenue side. On the cost side, alluded to it on the revenue side, but on the cost side as well, which is that risk profile of the population you are enrolling. Again, if it really is the sickest of the sick, and based off of your resources, you're focusing on top 1%, highly likely that you'll be spending more than 20 minutes on that face-to-face. Now, if you're already doing that, then getting the extra money makes sense. If this is a new service that you will be providing, you need to take that time and cost into account. The care team mix is another item to think about as you are figuring out what it's going to take to support these services. For some clients, they're already involved in patient-centered medical home. They're already involved in other programs, and they may have the personnel already on site and already working with these patients. For others, this means making the case for new hires. And lastly, of course, is the health information technology that's required. As mentioned in some of our other slides, certain services must be documented or delivered via a certified technology. There's patient identification that you'll need to invest in some way, some time tracking, the creation of the care plan, the communication of these care plans with other providers as well as with the members who have signed up for the service. So there, and again here, this will vary by group, but how much technology, additional technology, will you need to invest in order to meet the requirements for billing for this code? So we don't have all the answers for you because, of course, this is going to vary by organization, but we have done on the next slide is taken a scenario and show you how those enrollment levels really matter. In this case, we have set up a scenario where it's a 20-physician practice at 2,500 patients per panel. It comes to about 50,000 patients. We made a couple of assumptions across the scenarios. One is that 70% of the Medicare fee-for-service patients have 2 or more conditions, and in reality, we won't be billing every month, but we'll bill about 80% of those enrollees every month. And given that scenario, we then took 2 different situations. On the left-hand side, we have a low enrollment for a couple of reasons. One is just that only 11% of my total population in this case is Medicare fee-for-service, and 30% are consenting to actually enroll in the program. That leaves me with about 924 enrollees and an estimated monthly revenue of about $40,000 per month. On the right-hand side, I have a slightly different scenario or situation. I have more Medicare fee-for-service patients in my population and a greater enrollment consent of 60%. In this situation, we're looking at roughly 7,700 enrollees and an estimated revenues of $325,000 per month. Now, with this information, we know that each organization is going to be evaluating how to deliver this service effectively and that makes sense financially. We're going to hear a little bit more from Marlene about how she presented this in her organization. But first of all, we wanted to do some polling and so that we can hear from you and you can hear from your colleagues about your plans.
Thank you, Marina. That was a very helpful introduction, and the model really elucidates some of the key drivers that people need to think about. So our first polling question is, how many of you are going to bill for CCM? I'll give you a few seconds here to submit your answer. Okay. And here are the results. So many of you are thinking about it. Many of you are on the fence. Hardly anybody is saying no. Let's go to the next question. How many of you have the HIT to track time? And here are the results. Most don't, and quite a few do have the HIT to track time associated with this program. The next question is, do you have the HIT to identify your population? And here, most people do. 82% have the technology to identify the population eligible for CCM. Do you have the HIT to create care plans? And the results say yes, that 74% of you do and a quarter of you do not. And the last question is, do you have the HIT to remind care teams to complete 20 minutes each month? And the results of this last question indicate that most of you do not have the HIT to remind care teams to complete the 20 minutes each month, while quite a few of you claim that you do. Okay. That was very interesting, and I think we'll take some of that into account as we go through the discussion now with Marlene from Northeast Georgia Diagnostic Clinic about how they've already begun implementing the chronic care management fee. So Marlene, thank you very, very much for being here today to share this experience with us. Can you please first give us a little high-level overview of the Northeast Georgia Diagnostic Clinic?
Sure, I'm happy
happy to be here. When you look at our practice, we've got over 40 providers that are covering 7 different specialties. And in addition to that, we've got full on-site ancillary services, radiology, pharmacy, sleep lab, infusion, et cetera. And our population is somewhat unique from other places that I've been in that we're very heavy on the Medicare side, and almost 64% of our patients are in that Medicare category. We do currently have one shared savings contract that's in place. We've got a few quality bonus programs, and then we're also working on some value-based contracts that are in the works. And then we're definitely on the PCMH journey, both for the impact that we think it makes for patients and for our providers, as well as for the reimbursement incentives that it will bring to us as well.
Okay, let's go to the next slide. Marlene, considering the model that Marina presented and your own calculations, can you please tell us how you made the business case to Northeast Diagnostic Clinic in Georgia to pursue CCM?
Sure. I think that making the business case for CCM was fairly simple for us once we really sat down and analyzed our data. When you look at our very large Medicare population and the fact that the majority of those patients have multiple chronic conditions, then I think the numbers really helped us to realize that it was the perfect program for us. The challenging part, I think, for any new program is getting the funding approved to be able to move forward, and the CCM revenue and the dollars that it brings really helps make that growth and the need for additional services far easier. It was pretty simple for us to use our technology to analyze our population, look at and identify the number of patients that we knew would qualify based on their conditions, and then present that in such a way that it was a no-brainer for our partners to approve it. I actually broke it down to, here's the potential revenue if you take that total population of patients that we know will be eligible for it, and you apply even a 10%, a 25%, a 50% mark to that, here's the potential revenue if we hit each of those numbers. And I think that that helps paint the business case perfectly and then allowed, in turn, me to get some additional FTEs approved to help bolster up our care coordination team. We also knew that we were already invested in care coordination as a part of our practice and our normal everyday workflow, even before our PCMH. And we knew that this program would help us to engage not just those most complex patients, which are the ones that my care coordinators were touching most often today, but it would also help give us some additional resources and some additional time to try to engage some of those patients a little bit earlier so that hopefully we could make a bigger impact before they reach that catastrophic point. I think it also allows us to kind of go beyond the waterline. Most of us in day-to-day practice end up focusing our time, whether it's the physicians, their nurses, or other staff like care coordinators, on those patients that are in and out of the hospital, that are needing a lot of hand-holding, needing a lot of resources. And we spend so much time focusing on them, but we're not really focusing on those other patients. And eventually those other patients end up at that same position. So this just allowed us to engage a little bit earlier with more patients and really help to kind of spread or share the caring, as we like to say.
Thank you. Next slide, please, Renee. So we talked a bit about identifying these patients, and many of the folks on the poll, on the webinar, through the poll question, said that they are able to do it, but we'd love to have you tell us, Marlene, exactly how you're going about identifying the patients that specifically qualify for CCM.
So we've got several different ways that a patient can end up in our CCM program. First off, we got our physicians very engaged in this process. We invested a lot of time up front really educating our physicians on the CCM program, what the requirements were, and not just that, but what the profile of the right patient looked like to be most appropriate for this program. We knew with a population like ours, there would be no shortage of patients that were, quote, eligible, but we wanted to make sure that the work we were doing was meaningful, and we weren't just signing up every patient, but the patients that we could really make a difference. So our physicians are very, very engaged in this process, And the majority of the patients that we have enrolled so far really did come from our physicians. And the normal course of their patient care every day as they're meeting with patients for their visits, they would identify patients that did meet the CMS criteria of having the conditions that they needed to, but also that they felt that those patients really needed the benefit of care coordination to try to make an impact there. We've also really used our FITEL data to identify patients. We want to make sure that we're not missing any of those patients that need the program most, whether they're poorly controlled patients, patients with certain important conditions that we focus on here within the clinic, or also, those patients that aren't coming in as frequently. So those patients that come in for offices and are in front of the physicians, it's easiest for the physicians to remember them and sign them up. But we want to make sure we don't miss those patients that haven't been in quite as frequently as some of the others. And then lastly, our care coordinators have been empowered so that they can refer a patient to their program if they come across one, either through some of their TCM work when they see patients that have been in and out of the hospital that are perfect for this program, or just patients that they're touching in their standard care coordination work that they're doing for some of our other programs. So really, those are the 3 key ways that we've identified patients to enroll them into our program.
That's very helpful. Now let's go on and talk about the enrollment process. As Marina described, there are some rules about this in the CCM guidelines. So Marlene, can you tell us about how you've implemented this from an enrollment perspective?
Sure. So for once the patient's identified, particularly if the physician is identifying an appropriate patient during the course of their visit, the physician will give the patient a really quick summary of the program, explain it to them, and then they will go ahead and obtain the signed consent. We did create a consent form specific to our clinic and that program that does meet all of the CMS requirements. And so they'll go ahead and get that consent signed, and then that consent is handed off to my team. Once that happens, then my team will really take the lead. They will officially kind of enroll that patient in our program. So we start by doing a couple of things. We go into our EMR and we tag that patient with a CCM alert so that anybody throughout the course of our entire clinic, no matter what department they're in, what provider they're seeing, whether primary care of one of our specialists, whether the nurses or somebody else is interacting, everybody's able to see that this is a CCM patient. And we found that that's been pretty helpful because as issues arise with these patients throughout the clinic, everybody knows that they have that assigned care coordinator to be an additional resource to help navigate issues with that patient. We also go into FITEL and we tag that patient as being a CCM patient within the FITEL notes section. What that allows us to do is to really generate CCM program-specific work lists for our care coordinators. So once we tag those patients, then I can generate lists of everybody within our CCM program, or I can break it down and just say CCM patients that have a certain care coordinator associated with them. So being able to do that allows us to generate the work list, and it's from those work lists that our care coordinators are really working and going through their lists every day to make sure that they're touching all of the right patients and getting everything that they need to in it. Once a patient is enrolled, then the care coordinator will kick off that initial call. And during that call, they're doing a really good assessment to try to really look at meeting that patient where they are today. How's the patient doing with their health condition? And also, how well do they understand their conditions? What's their health literacy when it relates to where they are in their disease processes? Do they understand their medications? Really trying to look at what their needs are so that we can help establish that care plan. They're also trying to assess whether the patient has a need for any additional resources, whether they're community resources, assistance with medications, really trying to get that full picture, or the rest of the story, as I like to call it, as to where that patient is now, so they can then help generate the care plan from that. At the end of the call, the care coordinator will set the follow-up date, again, within FITEL. They know that, I will say, the majority of our patients, it's probably a rare occasion where when we engage with a patient, we're not getting at least the full 20 minutes. If they did have a patient that, let's say, for example, it was a 10-minute call today for whatever reason, then they'll set their follow-up date for the next time they should call a patient within the same month so that we can get the full 20 minutes within this month so that we're able to bill for it. If their call is longer than 20 minutes, then they go ahead and they set their follow-up call barring any needs from the patient to be talked to sooner, then they'll set that for next month. So they have a really good way of tracking that. We also prioritize every patient. I don't think I mentioned that earlier. As we enroll the patient, there's kind of an overview of the information in the chart to set a baseline priority for that patient. So our care coordinators, as they're using their CCM work list, are working patients from high priority down to low. So at each call that the care coordinator will have with the patient, it's also an opportunity for them to update that priority and make sure that we've got it set appropriately. So if they need to escalate the priority because the patient's recently been out of the hospital or not, they certainly can. Or likewise, if they need to decrease that priority because the patient's doing far better, they have the ability to tweak all of that during the course of their call. So at the end of their call, they'll follow up. They also use the note section to kind of identify and queue up any key items from a goal-setting standpoint that they want to talk about at the next call. So if they're talking with a patient who's a smoker or somebody that they're encouraging to do more finger sticks or exercise, that type of stuff, really brief notes, but it helps kind of queue up for them the next time they call what goal-setting opportunities that they establish with the patient. The other thing that we find helpful is we use those patient summaries quite frequently where they're actually printed out and given to our patients. It's a visual that both our physicians and our nurses like because the patient's able to leave here with a visual of their most recent results as well as those goals. So they use that note section for that as well so that when they do provide it to the patient, it's a great reminder for them as well. We then have, created a note within our system so they'll do their documentation there and then they'll kind of move on to the next patient.
That's really excellent, Marlene, and thank you for explaining how you're using a combination of your EMR and FITEL to all of those types of things for notes and follow-up and priority and due dates and goal setting in the FITEL product to help manage each one of these CCM patients. Okay, now let's talk about an item that Marina talked about as being key to the to your revenue estimation model. I think, right. So we're talking now about the copay, and is that a barrier to consent? Because consent is obviously quite critical since it's mandatory to do billing. So Marlene, please tell us about how you've approached this and what the results have been so far.
I can tell you that going into the program, I myself was concerned that patients would have an issue with the copay that could be associated with this program depending on their coverage. And even though it is a relatively small amount, I think it equates to about $8 for our patients, I really was concerned that we'd have many patients that would be opposed to that. What we found was exactly the opposite. So far we haven't had any patients at all that have really had a concern about that potential copay. Overall, our patients have been extremely receptive and really very excited about the program, as have our physicians. And what we're finding is that the patients are so excited about having this dedicated care coordinator that they know will engage with them, becomes an additional resource for them. And it really seems like they think that it's an easy price to pay to be able to have that kind of service associated with their care here. So far we've had no problems at all. And I'd say, in fact, the reception has kind of been overwhelming. From the moment I said go, and initially when we started it, I didn't open it up to all of our physicians. I took a handful and I said, okay, we're ready to start enrolling. And literally in the first 2 weeks, we had 350 patients that were enrolled with our program, and no shortage of more. So I probably have the potential to have more patients now than I certainly wanted in that early in the program. But so far, it's just been very well received from both our physicians and especially our patients. Our patients are enjoying it. Our care coordinators are enjoying the work that they're doing with them, and not a mention at all from any patients about the co-payments. I think our billing office was set up to be able to handle that. These patients are used to having co-pays for most of their services anyway, so it's not a foreign concept to them. And really simple tweaks to billing workflows, I think, make it work for us.
That's excellent. Very helpful information and encouraging for folks who are considering this program. Now, let's talk about the critical issue of time tracking and the types of activities that your care coordinators and other staff are providing to make up the 20 minutes each month.
So I think I mentioned we do document the number of minutes spent in FITEL. The FITEL notes, I don't like people to duplicate work anywhere, so the FITEL notes that we're putting are very short, sweet, and to the point. We do keep in mind that, we don't want to put anything in those notes that we don't want a patient to see, because when you do print out those notes, that information will print out on that patient summary as well. But they do document the number of minutes that's spent with the patient for the care coordination, as well as the goal setting type things. And what we find is that really helps cue things up for the next call, and it gives them a really simple reminder of the key things that they wanted to make sure they covered in the next call without having to go dig through a whole litany of notes to kind of create what they wanted to talk about in the template. And that's not to say that they don't use the EMR for that information. They certainly are up to date in the most recent physician notes and any changes in the physician care plan. But it's just a short, sweet reminder for them that they want to talk to the patient again about smoking, or that the patient promised that they were going to start exercising 3 times a week. And so it's just a simple reminder to the care coordinator, and then again for the patient if we print out that patient summary and provide it to them. The nurses also document all of the CMS required elements. In our EMR, we built a structured care management note. And when we built that note, we were trying to make sure that it incorporated everything that it needs to. So the note template that we built is compliant with the CMS program, as well as the needs that we had for PCMH and for our standard care coordination work as well. So within that note, they're able to have some key reminders and some visual cues based on the headers we put in that structured note. And they're able to click through pretty quickly. We tried to make it as easy for them as we could. So for each section, they're able to click in and then kind of highlight the certain items they wanted to incorporate. And what we found is that's a lot easier for them than having to do a whole ton of manual kind of narrative throughout the note. They do have the ability to add additional narrative comments if they need to, but the bulk of their note really is structured in a template format so that they can click through it. When we come to our call, so we made our initial call to really be a full assessment of the patient, where they're at, how much they understand their health, as well as a full med reconciliation. I think most of us would agree that that's one of the most challenging things, and while everybody tries to do it, what we found is that when our care coordinators really engaged in a good med reconciliation with our patients, they were able to capture a lot of information that hadn't been captured in the clinic, whether that's that patients were telling the doctors when they were here that, yes, I'm taking all my medications the way I'm supposed to, but the care coordinators were really identifying that maybe they weren't quite taking it the way they should, or they had stopped certain medications because patients were having a reaction, and that information hadn't been communicated yet. So that full med reconciliation is one of the first things that they do. We also found it was a perfect opportunity to use some standard tools like PHQ-2 or 9 for depression screening. When you look at patients with chronic conditions, I think the data is pretty clear that many patients with chronic conditions also suffer from depression, and that depression really impacts that patient's ability to better self-manage their condition, which is what we all want for them. And while depression may have been mentioned in a note here or there, very, very few times did we find that there was really good documentation as to true depression screening using a standardized tool. So that's one of the things we implemented as well. And so they are doing those screening tools. That's being documented in our system as well. And then we also made it a point so that they can track any of the time, not just on their care coordination with their calls with their patients, but also any time that they're spending making referrals, setting up community services and resources for that patient. Any of that other additional work that falls into the CMS definition of care coordination can also be captured as well. So they're using a good combination of FITEL and the EMR, and so far it's worked really smoothly for our care coordinators. We made it a point to make sure that they're equipped, so they both have, they all have dual monitors, the larger size dual monitors on their desk, so they're able to have FITEL on one screen and the EMR on another, and it's just really worked well for them that way.
Marlene, that is very detailed and very helpful. Gives us a great visual of how your care coordinators are working every day as they speak to these patients and complement what is going on at the visit with the non-face-to-face support that is intended by CCM. One of the things that you did say, and I'm going to ask you one question here, that I think will really help. You just made the point that you are using complementary technologies. How important is, for example, the tools, the automation tools, to help you scale once you get past this initial phase where you're just starting up, when you ramp it up to everybody? How is this going to help you make sure that you can go across all of the primary care docs at Northeast Georgia Diagnostic Clinic?
I think I'd have to say that technology for us is critically important. The more that we can utilize technology to really automate processes, whether it's the identification of patients, it's the documentation piece, or the tracking of information, the more we can automate those processes and really harness technology, which I think goes back to key of PCMH and that mindset anyway. The more we can automate those processes, then the more patients we really are able to touch. I'm a firm believer that nurses need to have the tools to do their jobs, and the more we can automate them, then the less manual work that they're able to do, and the less manual work they're able to do, then the more patients that you can touch. So if you're really looking at how you can build a program that is robust to touch your entire population, I don't see how we'd be able to do it without the technology. And really, I always say that we're only limited by our creativity and how we can come up to use the system. So having these robust tools, it's really a challenge to think of all of the ways that we can maximize those to make things a little bit easier for everybody.
Thank you. That's very, very helpful for everybody as well. Okay, let's go to the last slide to have you help us wrap up what recommendations you have and the lessons learned so far from your initiation of the CCM program.
I think the most important thing in my mind is really starting by doing a comprehensive look at your patient population. You've really got to understand what your population looks like, what the prevalence of conditions is within your population, and really help to identify what that whole picture looks like. I think that helps paint the perfect picture of your starting point and also the potential implications that it can have to your revenue. And then those things together will help you best gauge what your staffing needs are going to be. And I think you've got to also keep in mind that unless you have an endless supply of trained care coordinators, you just can't plan to touch everybody, from day one, from the beginning. So using that data and from analyzing your population, really drill down and look at who are those patients that are most important and prioritize them so that from the beginning, you're really touching those patients that need the service most. And that you're not leaving anybody behind. I always worry about the patients that kind of fall between the gaps, and make sure that not only are you prioritizing your patients, you're not leaving anybody out that really needs the service. And then I think lastly, as I just mentioned, utilizing technology wherever you can, I think is essential so that you can scale the program. The more that you can automate, the more you can adopt some lean, efficient processes, then I think the more patients you'll be able to accommodate. And I always say these programs are great for everybody. People have different motivations for doing things. Some people do it because it's a great revenue generator. Some people do it because it's the right thing to do to impact patients. And I'm a firm believer that this is one of those programs that's a win-win for everybody. So whatever your reason for kind of tackling it and going down that path, I think if you really can harness the technology, assess your population, then it'll make it a pretty clear path. And really kind of help paint the business picture for you to be able to get, if you do need additional resources, to be able to get those to move forward.
Thank you, Marlene. I think that this is an extremely valuable component of our webinar today, to hear directly from the field how one practice like yours is implementing and achieving early wins with the CCM program. Thank you very much for all the detailed and descriptive information.
Absolutely.
I want to call everybody's attention on the next slide to a brand new white paper that FITEL has just produced on the CCM fee in particular, and how to use HIT in conjunction with it to be successful. You can access that on our website, and as Renee said, we will be providing links to everything, the presentation and the white paper, et cetera, to all those who have registered. On the next slide, we have provided 3 key references that will help you understand some of the details and answer some of the questions that you have asked already that we may not be able to get to. In fact, I know we won't be able to get to many of them with just a few minutes left. But these are great sources, and we'll probably add a couple of others when we send out the final presentation to those who have registered. We do have a couple of minutes left for questions before we wrap up. I have to say we have received an amazing number of questions, many of them asking questions very specific to the details of the billing process and eligibility. So I would refer you to some of those documents that I just mentioned. But then we also got some interesting questions too that Marlene, you might be able to help us with. One is, we got quite a few questions on, do you see a role over time for mobile technologies to support patient engagement with regard to chronic care management?
I would say absolutely. I think what we find, and again, I can speak specific to our patient population, but what we find is many of our patients may not have a computer, but they sure enough have a cell phone, or they have a tablet, particularly today. So I think the more technology that you can put in the hands of patients that is user-friendly, isn't overwhelming, and really gets them to engage in whatever way you can, I think is a great thing. Conversely, I think that the ability to have data, I know I'm one that I will pull up vital data on my iPad probably daily. So I think that whether you're looking at your staff and your physicians being able to do it or able to put it in the hands of your patients, I think absolutely.
Yep. Marlene, are most of your assessments done by phone, or are you also using any secure messaging or email or other things that are allowed under the definition of non-face-to-face communications with patients?
I would say all of our assessments are done by phone. Outside of that, there is some electronic communication between our coordinators and our patients, whether that's more so through our patient portal, but in some cases email as well. You know, with a Medicare population like ours, I think the first thing that everybody says is, oh, you know, these patients don't have computers, they're not online. And what I say is, yeah, you'd be surprised at the number of them that are. The grandparents that are on Facebook are the same grandparents that are able to log into the patient portal or communicate by email as well. So I think sometimes there are some myths out there about particularly this older population and using computers and using mobile technology, and it certainly doesn't seem to be true in our case.
Okay. Do you have any more information to provide folks on your estimation of whether you believe the costs of providing CCM services are going to be less than or at least break even with the revenue?
Yeah, I certainly, you know, if somebody wants to reach out to me, I'd certainly be able to share kind of our experience one-on-one. In our case, it certainly is not just a break even, but is a really good revenue maker for us from a profit standpoint.
Okay. And then one last question. The 20 minutes, you know, how does that need to be documented? Do you need to specify all the little activities and have that available, or is it just 20 minutes?
No, yeah, so you do have to, so CMS requires that you do document in your EMR the number of minutes that are spent. You don't have to document all of those little activities. So our folks, through the structured note, and that's what I'd encourage for anybody, is any opportunity that you have to make a consistent note that would be the same no matter which care coordinator on your team is doing it. I think that from a quality standpoint, you'll get the best outcome. So I'd encourage everybody to look at creating a template that works, again, not just for the CCM program, but if you can make sure it's consistent with, if you are going down PCMH, kind of build the things that you need so that we have a care management note that can be used for CCM, and it has the things needed for that, or it can be used for some of those other needs that we have as well. And so you don't have to give every single detail of, in the 20 minutes, I spent 10 minutes talking about this or that, but it does need to have a good summary so that if you are audited, that someone could look at it, determine, yeah, you talked for 20 minutes. But then most importantly, I think, at least to me, and I think it goes back to your motivation as well, is making sure that you've got some good information that can help show that you're making an impact for the patient or for the physician program.
Thank you so much, Marlene. We're right up at the bottom of the hour here, and Renee, I'd like to turn the last slide over to you.
Great, thanks, Karen. As we mentioned, if we did not answer your question, we will do our best to follow up with you after the event. At this time, I'd like to thank Dr. Hodak, Marina, Marlene, and Karen for your time today. This was truly extremely valuable. As a reminder, we will follow up with everyone with the presentation, a link to the recording, the chronic care management paper, as well as the other resources that you saw within the presentation. Please look for it within the next 24 to 48 hours. Also, please be sure to take the brief survey so that we can share the results with you. There are a lot of different types of organizations as well as attendees on the call today, so it will be really interesting to see what kind of response we do get as it relates to this particular topic. And finally, if you would like to, please join us on March 26th from 12 to 1 p.m. Eastern Time for our next executive webinar series. It is The Power of Embedded Coaches for PCMH Practice Transformation with Dr. Swartz and DuPage Jai from Montefiore Medical Group. And at this time, the webcast will end. Thank you so much for attending today, and have a wonderful day.